But when it comes, today I am going to speak on female sexual dysfunction. And it is a very less discussed topic. As a gynecologist, when a patient comes to us for infertility problems, the mother-in-law, the father-in-law, they are very keen to hear about the fertility days when their daughter-in-law can make sex with their husband. But when it comes for pleasure purpose, it's such a taboo in our country that out of shyness, we even don't know the real statistics of the prevalence of sexual dysfunction among females. So I won't go into the statistics because these are really misleading and there is no real world true data in the Indians regarding the prevalence of sexual dysfunction. But among various studies, it was found from 40 to 70% in type 1 and type 2 diabetes. So as Germani sir has also told, we said if for pleasure purpose it has so many benefits, like it lowers the blood pressure, better immune system, we have a better heart health, and it allays depression, anxiety, and it's a natural pain reliever. Patients they get better sleep after sex, and after the release of the good neurotransmitters like dopamine and serotonin, it increases the intimacy and bondage between the husband and wife, and overall there is a stress reduction. So this was an original article in which 595 women with type 2 diabetes were studied, and it was shown that the longer the duration of diabetes, the older the age, and the more the obese patients, and those patients who had prevalence of cardiovascular disease and other complications of diabetes, they were more associated with sexual dysfunction. And metabolic syndrome, PERSI, and atherogenic dyslipidemia, these were independent predictors of female sexual dysfunction. And depression and marital status were strongest independent factors. So as Jumani sir has already described the difference between the psychosexual and organic factors, in a study published in a journal in 2011, it was found that psychosexual rather than organic factors are implicated in female sexual dysfunction in diabetic women. So when these were adjusted, after adjusting for depression and the years of schooling, hysterectomy and the marital status and age, diabetes, the odds ratio was 6.2. That is, diabetes mellitus itself remained as an important risk factor for sexual dysfunction in females. And diabetes affects all aspects of female sexuality, right from it leads to low desire, then low arousal, then orgasmic problems in the females. And it's even independent of depression in postmenopausal women. So how does diabetes lead to female sexual dysfunction? So we know that the hyperglycemia in diabetic patients, it reduces the hydration of mucous membrane, leading to poor vaginal lubrication, leading to pain during coitus and genitourinary infections. As we all know that diabetes is associated with candidiasis and recurrent UTIs. And recurrent UTIs and candidiasis, they itself reduce the frequency of sex, and they also leads to vaginal irritation, burning, discharge. So just if we take a good history, we can know, or these further leads to pain or general discomfort in the pelvic region. The vascular complications of diabetes, even they reduce the blood supply to the vagina and clitoris, leading to problems with dryness and arousal. Similarly, atherosclerosis, which is associated with diabetes, and vascular endothelial dysfunction, like Sir has already described about the role of nitric oxide, these leads to female sexual dysfunction among diabetic patients. The neuropathy and neurological disorders associated with diabetes, they also impair sexual response. Hormones also have a very important role in female sexual dysfunction, as low estrogen level reduces the lubrication of vagina. And if there is hypothyroidism, there is automatically low sexual desire. And estrogen deficiency itself, the patients have loss of interest, fatigue and depression. And those diabetic patients who had stroke or traumatic brain injury, they has a significant impairment in sexual functioning. So those patients who have, as we all know that diabetes lead to insulin resistance and PCOS. So PCOS patients also have And menopause itself leads to decreased estrogen, and menopause thereby leading to female sexual dysfunction. And for low libido, androgen deficiency has been an important contributory factor. So certain diabetic patients, if they are on certain drugs like anticholinergics or antihistaminic or certain antihypertensive medications or anti-lipid beta blockers, these are also an important cause of female sexual dysfunction. So I'll not go into the psychosexual component. My next speaker, Dr. Ashutosh, will be going to speak about this. So in one study, it was found that those patients who had cardiovascular disease, renal dysfunction or peripheral neuropathy, they had more chances of female sexual dysfunction. So urinary incontinence, if it is there, that also leads to female sexual dysfunction. Likewise, candidiasis, obesity itself, and arthritis leading to joint problems, and it also reduces sexual desire and female sexual dysfunction. So, as diabetes leads to reduction in the release of good neurotransmitters, like dopamine is required for desire component in the females, and epinephrine, norepinephrine and serotonin, these are required for arousal and orgasm in females. So these are also reduced. So how to make a diagnosis of female sexual dysfunction? Just by a good history and a gynecological examination, we can reach to and we can treat the patient to certain extent. Just we need to know the menopausal status of the patient, whether she's taking any chemotherapy or pelvic irradiation, and then if there is a history of vaginal pelvic injury, or she's having dyspareunia or itching perineum, or there is dryness in the vagina or discharge, or if there is even abnormal genital tract bleeding or urinary or fecal incontinence, these needs to be, and because we can always treat these conditions and we can always help the patient. And in females, the desire also increases and decreases according to the day of the cycle. It's the nature's mechanism that around the time of ovulation, the desire increases in women. Likewise, just after the menses, there is hypoglycemia in women, they don't feel like having sex. Likewise, so these days also needs to be kept in mind, and we can counsel the patient regarding these. So there are certain other symptoms which also we need to see whether the patient is having vaginismus, or she is having vulvodynia, or she is having non-coital sexual pain also, like there may be coexisting endometriosis, or there may be coexisting PID or pelvic inflammatory disease. So just by giving a course of doxycycline and metronidazole, we can help a patient a lot. So a detailed sexual and a gynecological and a psychiatry history, and also the history of taking, whether she is taking any birth control pills or a hormone replacement therapy. So a diagnosis can, we generally don't require any investigations, but we can do a KOH testing for ruling out candidiasis or vaginal pH. Even female genital mutilation, that's very common, and that can also lead to female sexual dysfunction. So as Allow sir has already told, so we need to take the women into a comfortable environment, and there should be a flexible conversation. Just the patient is wanting that the physician or the gynecologist should start asking them certain leading questions, and then they are free to ask their queries about the sexual dysfunction, because there are so much shyness in our country. So now coming to the treatment options. So first of all, as sir has already told, we need to the importance of diet and exercise needs to be emphasized for reducing for patients with reduced vaginal lubricants. So there's the definite role of foreplay before intercourse, and then water-based vaginal lubricants can be tried. Hormone replacement therapy, because this estrogen component it increases the blood flow in various in the vulva, vagina, so it combats the problem Then genital infections, just we have to treat it, and we also need to tell them about genital hygiene. For the patients who have dyspareunia or vulvodynia, lubricants can help, and they need to have a romance and more of foreplay as compared to the penetrative sex. For patients, those who having anorgasmia, so clitoral stimulation therapies or psychosocial support can always help. In patients with reduced libido, DHEA is a very good supplementation. It has worked wonders in patients with reduced libido because it increases the low androgen levels, especially in postmenopausal women. Even estrogen replacement and androgen replacement therapy, I will discuss it later. So, for sexual pain, even topical lignocaine has been found to be efficacious in various studies. For patients with low desire, bupropion and ADI or flibanserin, it's available now, it has been tried. In patients with low arousal, sildenafil and phosphodiesterase 5 inhibitor, these can be tried. And these sildenafil also increases blood flow in the vulva and vagina, and it has been found useful. So vaginal lubricants, moisturizers can be used. And coming to DHEA, how DHEA, it increases androgen levels, leading to restoration of circulatory levels of these hormones and improving the sexual function. So what are the hormonal therapies which are available? Androgen can be given, testosterone can be given in females either by 3 routes, oral, transdermal or intramuscular. So these are being found useful in postmenopausal women, but we cannot give them for long term because of the risk of side effects like hirsutism, acne and masculinization. But in postmenopausal women, it definitely improves libido. Likewise, hormonal replacement therapy like estrogen replacement therapy and the new use of tibolone, as it increases both the arousal as well as the desire in the female. So tibolone, Livian, it comes as a 2.5 milligram tablets. It increases the frequency of sex and overall sexual function. So it's because the combined estrogenic, it has estrogenic and androgenic properties. So flibanserin or ADI, it's a serotonin receptor antagonist, and it's the only US FDA approved agent for hypoactive sexual disorder in premenopausal women. It's a daily therapy is being given, but we need to counsel the patient regarding the increased risk of hypotension and syncope. Regarding sildenafil, there is one study which failed to show any significant benefits from oral sildenafil in women with low arousal. But we are using sildenafil in infertility patients to increase endometrial blood flow, and we have found good results as fertility rates are increased in those patients who have been provided sildenafil. Bupropion and mirtazapine, SSRI antidepressants, they can be used, as sir has Jumani sir has discussed about alpha melanocortin stimulating hormones. It can also cause vascular smooth muscle relaxation, and amongst them the new molecule is bremelanotide, which can be used by either oral, intranasal or sublingual. So we need to cure the hypoactive sexual desire syndrome, and definitely we have a role of diet, for which omega-3 fatty acids, they improve the libido, and in menstrual disorders and dysmenorrhea, premenopausal, premenstrual pain, they have been found to be useful. So pelvic floor exercises, Kegels exercises, they can also be very useful in patients with arousal problems. Likewise, Botox injection into the vagina, and the supplementation with L-arginine, it increases the NO nitric oxide production, leading to vascular smooth muscle relaxation. So PRPs, that platelet-rich plasmas, we have been using it, and in especially post-delivery patients for tightening of vagina, it's a new fashion in many bigger cities, and fillers can be used, G-spot augmentation it can be used, but these are all in initial stages. And of course, smoking, alcohol, and cognitive behavior therapy for vaginismus have a definite role. There is the prostaglandin, L-prostadine. It can also be used, and it has actually no side effects. And it also increases the vasodilation, and it has been found useful in a patients with 400. There was an RCT of 400 female patients, and it's also used topically. It's the new therapy of female sexual dysfunction. So prostaglandin's availability is also easy, and cost factor is also not there. So take-home message is further research is really needed, and same neurovascular complications that lead to erectile dysfunction in diabetic men lead to female sexual dysfunction, and we do have limited knowledge. What we need to do is just talk to the patient, have a listening ear, and discuss sexual health, be it a physician or a gynecologist, and on a lighter. And we cannot underemphasize the importance of tight glycemic control and reduction in hypoglycemia, because it has been found that it improves sexual dysfunction. So on a lighter side,